Good afternoon, at least for those folks that are in the Eastern time zone. I guess good morning to anybody that is logging on from further west of us. And for those of you folks that are in West Michigan, I don't think that summer is technically here yet, but it's certainly starting to feel that way. So welcome to our first Benefits Lunch Break webinar series for the summer of 2022. As most of you are likely aware, we host these webinars, the Benefits Group does, on the third Wednesday of every month at 12 p.m. Eastern Time. Join us next month, where my colleague Brett Leafgrower will be presenting on a new Illinois state law that may impact some disclosure requirements on your group health plan if you have employees who reside in the state of Illinois. So join us back here next month in July, and Brett will take you through those issues. If you have upcoming topic ideas, there's a Q&A feature that you can drop those in or take the post-webinar survey. We do review those. We have not been had any shortage for topics to discuss lately, but we do like to see that feedback, and may turn one of those suggestions into a webinar or webinars in the future. So please keep that in mind. And if you have something you'd like to hear us address, drop it in either of those features. Today, we are going to be discussing these machine-readable file requirements, which for many group health plans is coming very soon, effective in July of 2022. I think hopefully a lot of you are on the phone, are aware of these requirements. They were originally, we'll kind of talk about how they were delayed, but they were originally scheduled to come online in January, but were delayed for 7 months. And at this point, we have not received any words of additional delays. So just to begin with a high-level overview, for plan years beginning on or after January 1, 2022, these transparency and coverage, or TIC regulations, require non-grandfathered group health plans to disclose various information in 3 separate machine-readable files, or MRFs, and I may refer to those back and forth. The first one has information about in-network provider rates for covered items or services, or the in-network rate file. The second MRF is the out-of-network allowed amounts and billed charges for covered items and services, or what we call the allowed amount file. And the negotiated rates and historical prices for covered prescription drugs. And that's referred to as the prescription drug file. Little preview here. The prescription drug posting, the public prescription drug file, has been delayed indefinitely. So even though we have this requirement for many plans to post the in-network rate file and allowed amount file in July, no plans are currently subject to the posting the prescription drug file. Keep in mind that these regulations were issued in November of 2020, so they were actually issued before the Consolidated Appropriations Act of 2021 was passed. So these are actually regulations that were issued under some of the Affordable Care Act's transparency requirements. And because of that, they only apply to non-grandfathered group health plans. So here we can see which plans are subject to this machine-readable file requirement. All non-grandfathered group health plans, which includes both fully insured and self-funded arrangements. If you have a grandfathered group health plan, and I understand there's still a couple of those around, I think they're greatly declining in number, you are not subject to this machine-readable file requirement. Accepted benefits. So if you have a limited scope dental or vision plan, not subject to the machine-readable file requirement. Short-term limited duration insurance, or what we refer to as STLDI insurance. And then basically any what we refer to as an account-based plan, and this is where your benefits are set up with some notional account. So it would include things like health reimbursement arrangements, or HRAs, medical flexible spending accounts, health savings accounts, these new individual coverage health reimbursement arrangements, and then finally, qualified small employer health reimbursement arrangements. So again, those are plans that are not subject to the requirement to post these machine-readable files. So again, as I indicated kind of briefly in the beginning of this presentation, these regulations were supposed to be in effect for plan years beginning on or after January 1, 2022. But in August of last year, the Departments of Labor, IRS, and Health and Human Services delayed the effective date for the in-network file and the allowed amount files until July 1 of 2022. And they further delayed the requirement to post this prescription drug file until they issue additional regulations. And for those of you that are, keeping track with all the changes applicable to group health plans, you may be aware that under the Consolidated Appropriations Act, there is another very significant prescription drug reporting requirement that is scheduled to basically be effective in December of this year. And I think the departments are concerned that the prescription drug file reporting requirement under these regulations largely were duplicative of what's going to have to be done under the CAA. So I think the additional regulations that they'll issue will try to streamline those requirements. Keep in mind that if you have a non-calendar year plan, you don't actually have to comply with the requirement to post these machine-readable files until the first day of your 2022 plan year. So if you have a plan year that started in anywhere from January through July, you are going to have to post these machine-readable files beginning in July of this year. But for example, if you have a group health plan that runs on a September 1 to August 31 plan year basis, you don't actually have to start posting these machine-readable files until September 1, 2022, which of course is the first day of that plan's 2022 plan year. One question I've been getting a lot of from my clients is, do we expect additional delays? I have not heard any rumors about that, so I wouldn't expect that. However, keep in mind the way that the departments, if we think back to the requirement to to furnish the 1095Cs to your full-time employees, for those of you on the line that are subject to this, what we call pay or play penalty, those deadlines to distribute those 1095s to full-time employees were delayed several years in a row. But we didn't get the announcement of the delay until basically right up until we were at the deadline, the unextended deadline. And I think the reason for that is that gives some employers who are having difficulty or not prepared with this requirement maybe some additional time, but doesn't encourage plans to procrastinate. So if we do get a delay, I'm still not optimistic that we will. I would not expect it to be announced here until basically right before July. So what is the content required for all of these machine-readable files? And again, we're going to cover all three. I don't want to spend a ton of time here because for those of you that have fully insured group health plans, the insurer is going to have to do this. And frankly, for those of you that have self-funded health plans, you're going to have to rely on the TPA to at least make these machine-readable files available to you. Because if you think about it, either the insurer or the TPA is the entity that has all of this information. You do not. So first one is name for each health plan option. Then we have this identifier, which goes in order. You have to begin with a 14-digit health insurance oversight system or HIOS identifier. If that 14-digit HIOS identifier is not available, then you're supposed to use a 5-digit HIOS identifier. And if neither one of those HIOS identifiers are used, then you're using the EIN. If you actually have a plan that has its own EIN, it appears that you should use that EIN, but I think in most situations, plans don't have EIN, so we're probably likely going to use the plan sponsors. I would say for most group health plans, I would expect the identifier that will be used would be the plan sponsor's EIN because those plans would not have these HIOS identifiers. Additional content, the billing codes, and there's several different ways that you can basically comply with this. So any billing or other code used by the plan to identify items or services for purposes of claims adjudication or accounting or billing for the item or service. Again, CPT code, this HCPCS, Healthcare Common Procedure Coding System, Diagnosis Related Group Code, DRG code, or for the prescription drug file, at least the way we currently stand now, is the National Drug Code. You potentially can use other plan identifiers that are used by the payer identifiers that are used by the plan, such as hospital revenue codes. Again, I don't necessarily even know how that all works, so we won't dive into that anymore. Again, to put this content together, you're largely going to have to rely on your insurer if you're fully insured, or your TPA if you're self-funded. The MRFs must be updated monthly, and wherever they're posted on a public website, and we will talk about that. I think that's probably going to be the area where we generate the most amount of questions. We need to clearly indicate the date that the MRF was most recently updated. So now we're shifting gears a little bit. The last two slides, we discussed content that's required in all of these machine readable files. Here we're going to break off and just talk about the in-network rate. And again, I'm not going to spend a ton of time here, but we basically have to include the negotiated rates or comparable amounts under the plan with respect to each covered item or service that is furnished by in-network providers. If you have a plan that has kind of a more unique reimbursement arrangement, so for example, doesn't use negotiated rates, then the plan should disclose how the derived amounts are determined and to the extent these amounts are calculated in the normal course of business. If you do have an underlying fee schedule, the plan should include the underlying fee schedule in addition to the negotiated rate or derived amount information. And this requirement to post these negotiated rates or comparable amounts includes rates for both individual items and services and items or services that are more likely incurred and paid for on a bundled basis. Rates must generally be reflected as the dollar amounts and must be associated with the provider's either a national provider identifier, taxpayer identification number, or place or service codes. And while the dollar amount is the general rule, there are some exceptions to this. So if a percentage may be used if a plan uses a percentage of billed charge reimbursement arrangement or some other type of reference-based fee type arrangement to provide the reimbursement. So again, if we use a percentage of billed charges and that's how we determine the reimbursement, then potentially we can use the applicable percentage rather than the dollar amount. And if we get to a point that just we really can't disclose how we calculated these amounts in the Department of Labor's technical guidance, there will be apparently this open text field. And excuse me, my slide has got a misprint in there or a typo. It says my open text filed, but it's a open text field. You include in this open text field the description of the formula, variable, methodology, or any other information that's necessary for the departments to understand the reimbursement arrangement that the plan relies on. The last day of the contract term for each provider-specific rate that applies to each covered item or service, including the rates for both individual and bundled items and services. Again, where a reimbursement arrangement is not a standard fee for service model. So for example, maybe it uses a capitation or bundled payment arrangement. You must also indicate that you have this non-standard fee for service model. And then at the risk of stating the obvious, we don't have to include information relevant to prescription drugs, because that arguably will either be included in the prescription drug file that we have to publish later, or potentially be disclosed to the departments through the Consolidated Appropriations Act prescription drug reporting requirement. So now we're moving on. So we've kind of set the in-network file on the shelf here, and we're going to move the allowed amount file. There's a lot going on the screen. But we'll work through it here. So we have to basically include the unique out-of-network allowed amount. So what the plan allowed and the billed charges from the provider. These are out-of-network providers with respect to covered items or services that are furnished by the out-of-network provider during the 90-day period that begins 180 days before the publication date of the machine-readable file. So that's a mouthful. But if we publish the machine-readable file on July 1, 2022, we go back 180 days, that gets you to January 1, 2022, and we'll have to post this information for that 90-day period beginning on January 1, 2022, which I believe brings you through April 1, 2022. Remember, these files have to be updated on a monthly basis. So they'll be updated on August 1. Now we're going back to 180 days, which is only bringing you to February 1. But basically, each month is going to drop off a month and pick up another month. Keep in mind that plans have to exclude information related to a particular item or service, and provider, when including that information, will require the plan to report payments for amounts in connection with 20 or fewer than 20 different claims for payments under a single plan or prohibited by privacy laws like HIPAA. So I think the reason here is, let's say you have a plan that's not super big, but we know that a participant, or we know that a fellow coworker that's covered in the plan recently had a major procedure like an organ transplant. If that's if the plan is only paying for that organ transplant to that one provider, so we have far less than 20 claims, we're not to include that information. And the idea is to protect that person's privacy, because we could basically use that information to figure out who it was, where they got services, how much services were paid for. So again, if you have claims that are less than 20 different claims for payments under a single plan with the same provider, that information is not going to be disclosed. Or if we have any other disclosures that are prohibited by applicable privacy laws, which would both include HIPAA and potentially state privacy laws, to the extent that they were more robust or required more than what was required under HIPAA. So moving on, each allowed amount must be reflected again as a dollar amount with respect to each covered item or service that is furnished by the out-of-network provider and associated with the provider's NPI, National Provider Identifier, Taxpayer Identification, or TIN, or place of service code, and must include the aggregate of the actual amount the plan paid to the out-of-network provider plus any participant cost sharing. And I have a very easy example here. Participant goes in for whatever the allowed amount is $100 paid. That's the amount that is allowed by the plan to the out-of-network provider. The plan pays 80% of this because the participant is subject to a 20% coinsurance rate. The plan is going to actually report $100 as the allowed amount, not the $80 that just the plan paid. So it's going to include both the plan payment and any coinsurance or copays or shared spending with the participant. Here, we're going to talk about the additional content for the prescription drug file. Keep in mind, I'm going to go through this relatively quick because this requirement has been put on hold indefinitely. And frankly, I think may not even survive in light of the CAA having a much more robust reporting requirement with respect to prescription drugs. So again, reflected as a dollar amount with respect to each national drug code that is furnished by an in-network provider, including an in-network pharmacy. And this is the negotiated rates. Please notice on the very top slide, it's the plan's negotiated rates for prescription drugs reflected as a dollar amount with respect to each NDC that is furnished by an in-network provider. Again, you have to identify the provider but using NPI, TIN, or place or service code. And then the associated with the last day of the contract term for each provider's specific negotiated rate. So that actually sounds like a lot of information that's similar to the in-network file, only applicable to prescription drugs. Moving on, now we're going to have to also report the plan's historical net prices for prescription drugs. Again, reflected as a dollar amount tied to each NDC and identifying the provider either by NPI, TIN, or place and service code. Again, this requirement looks a little bit more like the allowed amount file because now we're publishing this information for the 90-day period that begins 180 days prior to the publication date of the machine-readable file. So that's very much similar to the allowed amount timing requirements. Again, they've got this particular privacy. So if we're talking about less than 20 claims for payment using a single plan and provider, that information is going to be excluded along with any other information that we think may, by disclosure, may violate any HIPAA or other applicable state privacy laws. In the historical net price, so remember these last two slides, there's the second reporting requirement under the prescription drug file. And the historical net price for a prescription drug is the retrospective average amount that the plan paid for the drug, and includes rebates, discounts, chargebacks, fees, and additional price concessions allocable to such drug. We're gonna have to probably get that information either from your insurer or TPA, or if you have a carve-out arrangement where you have your prescription drug benefit administered separately by a PBM, may actually have to work to get that information from them. So if the rebates and discounts are not known, you have to use a reasonable good faith estimate of your average price concessions based on amounts received by the plan in the prior reporting period. So again, I don't want to worry too much about this at this point, because this is publishing this prescription drug file is currently on hold for some period of time. And again, I think it could be largely different when we get revised regulations. Okay, so these MRS, machine readable files, have to be posted on a public website. Technically, it says a public website of the plan. But as most of my audience here knows, typically plans don't have public websites. I would say maybe the one exception to that is Taft-Hartley, multi-employer or union plans. They may have a website, but this information must be posted on a public website. It's got to be information in this digital representation in a data file that can be imported or read by a computer system for further processing without human intervention. I don't entirely know what that all means. And then you see some example permissible file formats, this JSON, I believe, and we'll kind of address maybe some particular TPAs that I've learned some stuff about over the past couple of weeks. My understanding is Blue Cross Blue Shield of Michigan is going to be posting these machine readable files using the JSON format. What do we mean by public website? It's got to be basically be accessible free of charge, can't require any user account, password, or other credentials. And you can't even really require the user to submit any personal information, even if it's not backed by a password. So it's got to be right out there in the public and accessible for anybody to download it. And let me take a point here. I go off on a little tangent. I get a lot of questions and like, how are my participants going to use this information? I mean, it's going to have, as we'll see here, it's going to have, these files are potentially going to be huge. Blue Cross Blue Shield of Michigan predicted that some of their files will be over a terabyte in size. So I don't think that the intended consumer of this information is actually plan participants or beneficiaries. Rather, and this is mere speculation at this point, I think third-party data aggregation services will start gobbling up this data and use it to build very robust databases, not only on in-network rates in various areas, but also what are the what are hospitals charging, the bill them, or facilities or providers charging on an out-of-network basis, the bill amount, and what's the plan actually paying for it, the allowed amount. So I think, again, I don't really see this as a participant disclosure. I see the intended audience as being these third-party aggregation services. Now, that doesn't mean a participant can't, access this information, but as we'll talk about in a minute, I think they should be aware that potentially clicking on one of these files may not be good for your computer if it's a super large file. May quite easily cause it to crash. So I think the question that I probably get the most of is if I have a plan, whether it's fully insured or self-funded, and either my insurer or TPA is going to be posting that information, posting the machine readable files on its public website, do I have to also post it on my public website, the plan sponsor's public website? And so there is these non-duplication regulations in the final rule, and basically says if a fully insured plan enters into a written agreement with the insurer under which the insurer will publicly publish the machine readable files, and the insurer fails to do so, any violations for failing to comply with the regulations would be imposed on the insurer, not the plan, or likely the plan sponsor. It's slightly different for self-funded plans. You are able to enter in this written agreement with the TPA of a self-funded plan under which the TPA will publicly post the machine-readable file. But the major difference here is if the TPA fails to do so, it's still the plan, or more likely the plan sponsor, not the TPA, that's going to be on the hook for any liability associated with the failure to comply with these regulations. The plan sponsor may be able to protect itself by using this written agreement through some type of indemnification. Another question I got is, do we have to have these written agreements? It doesn't look like the written agreement actually, for the fully insured is going to apply if you really want to shift the legal liability. But I understand most insurers and TPAs are prepared to post these files on their public websites or a place where you can access them, but are not necessarily willing to engage to enter in these separate written agreements at this point. They may push back and say, listen, our typical, if you're again in a fully assured arrangement, our typical policy with you says we'll comply with all applicable laws, and the failure that if we fail to do so and you incur any liability, we'll indemnify you for that. In the same sentiment, I think on the self-funded side with TPAs, maybe resisting pushing, that individual agreement. I don't think it is a prerequisite. It does not appear to be a prerequisite. If you still want to rely on your, for example, your self-funded TPA to publish these machine-readable files on your behalf. Now, keep in mind, if you don't have any written agreement with them and they fail to do so, any liability associated with that may be imposed on you as the plan sponsor, and you may not be eligible to get any indemnification from your TPA. So is the plan sponsor required to post the machine-readable files on the plan sponsor's website? Again, remember, it says you're supposed to post these on a public website of the plan. Most plans don't have public websites. If the insurer TPA publishes the machine-readable files on its public website, and so basically anybody can access it without a username or password, I would say the regulations don't appear to state that the plan sponsor also either has to post those on its own public website or more likely link to those. But I'm seeing a lot of, we'll talk about this here with respect to Blue Cross Blue Shield of Michigan and then Priority Health. For those of you who are self-funded through those organizations, you may actually have to post a link to these machine-readable files because it doesn't appear specifically that Blue Cross Blue Shield of Michigan is going to post this out on its public website. Rather, it's going to post this information in each one of its self-funded clients' group portal, which I understand you need a username and password to access. So therefore, it's not public under these regulations. So again, for if the insurer TPA publishes the machine-readable file on a public website and that is accessible to anybody in the public, it doesn't appear that you also have to include the file on your own website or links, but that may be a conservative approach while we kind of are navigating through this, at least initially. If you're self-funded and administered by Blue Cross Blue Shield of Michigan, you're going to need to link to these files on your website. Where you put that on your website, sometimes your guess is as good as mine. Again, it just can't have any of these requirements that you enter a username or password, or you enter identifying information. It's got to be on a public website. I believe the Blues hosted a webinar back on May 12 talking about where these files will be posted and how you can access it and how you can build the link. And I understand the links are, I'm looking at my co-person here who is much more technologically equipped than I am. It's not going to be a static link from what I understand. So it's automatically going to update when these files are updated monthly. I don't know if the term static was the right.
That sounds good.
Okay. Appreciate it, Jeff. For those of you that are maybe, and let me go back 1 second here. This is the Blue Cross Blue Shield of Michigan direction that they're going. So you will have to post the links. I would assume that's probably going to be very, very similar, if not the same, for any Blue Cross Blue Shield association that's administering your self-funded plan. So whether you're with Anthem, Blue Cross Blue Shield of Florida, whatever, I can't confirm that because I've only looked at the Blue Cross Blue Shield of Michigan, but I would certainly not be shocked. Priority Health sent out an email, I understand, to some of its clients last week And again, it's a little bit less clear whether Priority Health is going to stick these machine readable files on its public website, or if they're going to take an approach similar to the Blues and post it on an individual's, on a self-funded client's portal. But they did indicate that you also need to link to your own public website. So again, I would say the default, at least the conservative approach is right now, that you will want to link to those files. And I think probably linking to those files is better than actually copying them over and putting them on your website, again, because of the sheer size that some of these could be. And this is just basically language on the slide that has come right from the Priority Health website. So again, I think if you're with the Blues, you're with Priority, they're on top of this, they're going to put these files together, but you do have some action on your part because you may have to link to those files to your own public website. Fortunately, the regulations contain some relief. Specifically, they say if a group health plan is acting in good faith with reasonable diligence, they will not fail to be in compliance solely because it makes an error or omission in the required disclosure or due to the inaccessibility of a public website. When the information is required to be provided by a third party, such as a TPA, the plan will not be out of compliance unless it knew or reasonably should have known that the information provided was inaccurate or incomplete. And again, these regulations don't talk about a total non-posting of these machine readable files like your TPA or insurer buried its head in the ground. It's saying, is there going to be any inaccuracies? Are they anywhere incorrect? We won't necessarily have any compliance penalties. So that's, I think, a positive attribute of these regulations, because if you haven't figured it out by now, it's becoming increasingly apparent, group health plans are really going to have to rely on their insurers and TPAs to satisfy this requirement, because plans don't have this information. With that, we will move on to questions. I do see I have some self-funded, or I do have some questions here, so I will review those, and we'll get through those, as many of those as we can. So the first question has to do with this non-opioid disclosure form, which is not anything required under this law. This is a Michigan requirement. So it says, regarding non-opioid disclosure form, our organizations, for example, universities, financial institutions with no affiliations to medical facilities, required to provide to their employees. There seems like a lot of confusion regarding who is responsible for making this form available. The form has nothing to do with employment. Please advise, what is the employer's responsibility, if any? So back in 2018, I'll quickly answer this question. The Michigan Department of Health and Human Services basically published this standard non-opioid directive form. And if I fill this out and file it in my medical records, my providers generally can't prescribe me an opioid unless I'm in the hospital, my provider thinks it's medically necessary, or I'm outside the hospital emergency setting and my prescriber thinks it's medically necessary. In 2022, the state of Michigan amended that law and says insurers have an obligation to include with their typical enrollment materials this form. I understand that, again, from that May 12 Blue Cross Blue Shield webinar, I understand that if you use the Blues standard enrollment materials, that form will be in there. If you don't, you may need to put that form in your own. Again, this is a requirement imposed on insurers. So does an employer have any legal liability to put on this? Probably not under the law, but maybe contractually with their insurer or TPA. However, if you're self-funded and you're at least not, you're a private employer subject to ERISA, arguably this state law would be preempted by ERISA. You don't have to provide it. Keep in mind, to the extent that you think it's valuable, that people are aware that this form is out there. Clearly, we have kind of an opioid epidemic here, and lately, and so maybe you see the value in providing this, even if, for example, you're a self-funded group, not technically subject to this. We are self-funded, offer 2 high deductible health plans with an HSA as well as 1 PPO plan. we need to post the PPA only and not the HSA ones. Well, that's not exactly true. You're actually going to have 6 machine readable file requirements. It's going to be, you're going to have the in-network file for the 2 high deductible health plans. You're going to have the allowed amount files for the 2 deductible health plans. And then you're going to have the in-network and allowed amount files for the PPO plan. So you're actually going to post the machine readable files for both high deductible health plan option. The HSA, you're not going to report any information reported, about the employee's HSA contributions or their HSA distributions, but the machine readable file is going to apply separately to your 3 different options here. Again, that would be your 2 high deductible plans and your 1 PPO plan. For further clarification, if Blue Cross Blue Shield posts on their website, does that mean we also need to post on our company websites? I think that's not entirely clear right now. Again, if you're a Blue Cross Blue Shield of Michigan, you are going to have to link these files to your website because they are posting it behind a firewall, if you will. So it's certainly not public. If you work with another TPA that posts it right out on their public website, I think it's more arguable that says you don't have to post it. Again, I have a lot of clients that are still doing the links to take the conservative approach at this point. To reiterate, we are fully insured. So if we have a written agreement with insurer, we do not have to post on our public website. I would say that is absolutely correct. So if you are fully insured and you did get this written agreement, you don't have to post in your public website because if the insurer fails to do it, they will be the one on the hook for that. Will you please revisit comments on Blue Cross Blue Shield not providing a link that allows access to the MRF with a password? Makes no sense that they would set it up this way. I am not going to defend or comment on how they decided to approach this, but again, the MRS, the machine readable files, are apparently easily posted in your group portal. This webinar has instructions about how you apparently can very easily link to those files, and you can put that link on your website, and that should satisfy your obligations. And again, the nice thing is because these links won't be static, it's kind of like, for lack of better terms, set it and forget it, because you're not going to have to keep going and updating those links every month as the machine readable file is updated. If all plans using the same network, why does the plan sponsor with more than 1 plan need to post duplicate files, 1 for each plan option? I totally understand the question, and it makes a lot of sense to me because it's going to be reporting the same information in just 3 separate files. So it seems like that's very, very duplicative. But at this point, if the plans use the same network, we still have to have a separate in-network file for each plan option. Again, even if the networks are the same. Now, maybe we'll see some additional clarifying guidance from the departments as as more and more employers come online with this and are responsible and they get feedback and saying, hey, why are you making us do this? This seems awful duplicative. But at this point, each plan option has to have its own machine readable file. With that, it looks like we are out of questions. Again, thank you everybody for joining us today. Please come back in July 20, I believe was the date, for the webinar with my colleague, Brett. And with that, everybody have a great month. Thanks so much.